Psychoanalytic psychotherapies dominated the treatment dialogue for roughly the first 15 years. That has now been replaced by the use of multiple modalities. Learning how to treat borderline patients was largely a matter of the handed-down wisdom of what the particular supervisors in one's training center was. That's been replaced by evidence-based treatments. Originally, borderline patients were treated with generic treatments which had been thought to be good for everybody or that were learned to be effective for other patient groups and then applied to borderlines. Now we have disorder-specific treatments. For a long time, borderline patients were thought to be very treatment-resistant, if not untreatable. Now we know that most borderline patients will remit, and the treatments expedite that. The change that I'm going to talk about this morning is one that goes from the idea that you need to be a specialist with extensive training into a model where good clinicians with more modest training can do well by the vast majority of borderline patients, what I call, or I think actually Anthony Bateman coined it as a generalist model. Status of treatment for borderline patients, despite all the advances made primarily through the evidence-based treatments, but also the collective wisdom about these patients, is still not done consistently or well. Most clinicians don't like treating borderline patients and actively avoid them. There is a shortage of adequately trained BPD treaters. The first wave of interest in treating borderline patients came out of the seminal contributions out of Kernberg and was followed by a group of other psychoanalysts who encouraged relatively intensive, long-term treatments with borderline patients. This slide documents the number of books written by psychoanalysts and in the early years in the 1970s, 80s, and 90s. Roughly 54 books, 59 I guess, books were written during that period by psychoanalysts. What those books did more than anything was document the problems encountered. Indeed, somewhere during that period, I was thinking that a randomized controlled trial ought to be done on psychoanalytic treatment for borderline patients. But I thought first I ought to be able to find cases that verified the fact that the successes were possible. I'd had only very mixed success, to say the least, in my own practice. And Bob Waldinger and I scraped around and found 5 cases and made a book of it. But the basic lesson was that these were rare. And the model of treatment that was used was not really typically psychoanalytic. It was very supportive forms of intensive therapy. Why didn't traditional psychoanalytic techniques work? The neutrality encouraged projections, the abandonment. Got a nice slide on that. I don't feel like we're making much progress with my abandonment issue, doctor. You can sort of see how the analytic situation would actually aggravate the problems. And it did so in other ways too. Interpretations of negative motivations, that was a large part of Kernberg's contributions, the aggression, which was often walled off or latent. The interpretations of that usually had negative therapeutic reactions. That is, it was experienced as blaming and invalidation by the patients. And the inherent passivity within the psychoanalytic stance, where you follow the patient's lead, was experienced as disinterest or neglect. Now, this is Otto at the time of his seminal contributions. Over the next 20 to 30 years, there were 4 successive modifications of his text about treatment of borderline patients. Became transference-focused psychotherapy and became an empirically validated treatment eventually. Amongst the lasting contributions from transference-focused psychotherapy were splitting, the shifts from idealization to devaluation, what became identified in later in other ways as dichotomous thinking, black-white thinking within the cognitive realm. The focus on conflicts within about aggression and their effect on the sense of self. If one accepted that one is aggressive and hostile, then one is a bad person, and if one projects it, then one is a victim. That literature chronicled the countertransference reactions and the enactments which clinicians responded to borderline patients to in a way which set up a warning flag for everybody. And certainly that accounted for a great deal of the negative stigma attached to these patients. But it offered the hope that borderline patients' dichotomous or split thinking can be reconciled by clinical interventions. One of the problems or failures of the transference-focused psychotherapy model is it objectified patients. The therapist was still an expert who was making observations about a person that was not like them. And it underestimated the environmental and therapist contributions to what the patients were saying and doing in the office and in their lives. Underestimated social learning deficits. And most importantly, it was insufficiently supportive. I once chided Otto about that, and he acknowledged that there was more support within the TFP model than he talked about, but he feared that if he said that, people would absorb that part of the lesson and ignore the rest. Enter Marsha Linehan. This is her around 1993 when DBT was introduced. Now, the DBT model of treatment was radically different than the psychoanalytic. The therapists were very active coaches. It was combined with the group therapy twice a week, group therapy. Therapists made themselves available 24/7, and it had a sound empirical base. And this mounted a wave of enthusiastic treaters for borderline patients, which is still growing, and it remains sort of the standard. Sometimes it troubles me that people talk about confuse DBT and BPD as if there is only DBT and that is the treatment. The interest in DBT and its compelling message, or its message, became more compelling when in 2011, the New York Times reported on Marsha's revelation of her adolescent history, in which there was a great deal of self-harm herself, and she spent a great deal of time in the Institute of Living. Amongst DBT's lasting contributions are that its supportive real person interventions. There's a focus on emotional awareness and expression. There's behavioral failures are skill-based as opposed to conflict-based, and thereby responsive to training or retraining. Group therapy was a desirable and required complement to individual therapy. An ongoing case discussion was required. So what they call consultation groups is something which, without naming it as such, was a built-in safeguard against what a previous generation had talked about as countertransference problems. Amongst its problems are that it is overly rigid and rule-bound. It doesn't have to be that way, but oftentimes practitioners get religious about you having to be on model, and it undervalues meanings, aggression, and the role of relationships. I think Marcia would say, and anybody who practices DBT would acknowledge, that the relationship formed with the patient is a very important part, but it isn't identified as a central part of the therapy and what works. It's ahistorical and non-personological. It's interesting, it's a biosocial model, sort of the psychological, that is the individual, the differences from one person's psychology and their personal history and from another person's personal history is not emphasized at all. And it underestimates resistance to change and secondary gain. That, I think, is because when you start out treating a low socioeconomic group where it's wonderful to have like 5 hours of treatment a week, where the alternatives, not much at all, people, you don't encounter the same resistance as you do when patients have lots of options. Enter those rogues from England. That's Anthony Bateman on the left, the fellow on the right's here today, smiling. Peter Fonagy, and you're going to hear from him later today. They were both psychoanalysts, but sort of mavericks. Peter Fonagy is primarily a developmental psychologist who was working on attachment and studying the interactions between parents, largely mothers, and their children, and identified the problems that occurred when parents failed to identify the feelings in their children and talk about how the child was affecting them. And this gave rise to a model for understanding the interactions, understanding what they posited as core psychopathology of borderline personality disorder, of inability to mentalize. Inability to mentalize has to do with knowing how, reading the other person, being self-aware, and knowing how your mental state is affected by the other and vice versa. So in this way, the interactions with the clinician, and this treatment like DBT has both a group therapy component and an individual therapy component. The interactions between the borderline patient and the clinicians and the other patients in groups become sort of like a laboratory for looking at misattributions and then taking a not knowing stance are there other alternatives, and asking the patient to sort of start thinking on their own that their interpretations may be wrong and coming up with options. Amongst MBT's lasting contributions is that it was derived from an empirical developmental base. To me, this is always wonderful because it was the promise of psychoanalysis is that what people do as adults in some way was related to their childhood experience. And that was and remains a very compelling model for understanding adult psychopathology. And this was really a sort of, to my mind, maybe the first and only example of that kind of application actually working. The focus on interpersonal misattributions. It brought the patient-therapist reactions into the therapy, specifically not knowing and asking about how each. Amongst its problems is it doesn't address sexuality or aggression. Aggression is largely seen as secondary, which is, from my point of view, very useful clinically, but not necessarily true in terms of the borderline psychopathology. Underestimates the value of interpretations. That's sort of something you do only occasionally late in the treatment, and underestimates the value of confrontation. And the theory and the practice lack specificity. As much as I have attended mentalization conferences and learned things from it, I'm never sure where the boundaries are when I'm on model or off model. And that's both a strength and a weakness of it, because I think that the ultimate contribution here is that the mentalization, the process of learning it, is something that is core maybe to all effective psychotherapies. So we have an array of evidence-based treatments, going from the radical behaviorist, which is how Marcia defined herself, to a Freudian model, which is what's the nature of the trouble and when did it begin? It's in inquiring, curious, open-ended. Let's drive around and see what happens, which is a very operational, behaviorally oriented, fix the problems. So this is an array displayed in another way, DBT being the most behavioral. I didn't say much about schema-focused therapy, largely because it has not had a theory that has, and an empirical base or a training it's not been widely known and distributed. Mentalization and transference focused on the right. In the middle, there's this generalist model, which I'll spend some time talking about now. GPM is in particular. After the first wave of studies were done, which identified the merits of the big three, TFP, DBT, and MBT, they all were required when they were wanted to go back and confirm or verify their effectiveness, having at that point to have comparative treatment cells which were active and where they could assure for ethical reasons that the patients who were not receiving it were receiving an active, good enough treatment, so they had to be manualized. And the first of these, maybe the most impressive in a way, was the study on transference-focused psychotherapy, which showed that an expressive, supportive psychotherapy did just as well, although it had less than half the number of appointments. It was basically a once-weekly treatment. There was a DBT cell in that, which also did about as well, but Marcia would complain that it was not good DBT. But the point here is that the supportive psychotherapy, the less intensive arm of the three-arm controlled study, did very well. The second was a case management therapy, which was equal to cognitive analytic therapy. This was done by Andrew Chanin in Australia. Again, a less intensive, more case management oriented treatment did as well. Then in 2009, Bateman and Fonagy published their second controlled study with MBT, and this time with a controlled comparison groups called Structured Clinical Management. It too did just as well, or nearly as well. I'm sorry. Okay, we'll have discussion, okay? It did well. The patients did well. And then finally, in the same year, the controlled trial with good psychiatric management did as well DBT. And in this instance, the DBT, this is a study, Shirley McMahon's multi-site study done in Canada. Marcia actually called me to let me know about the results and to say that she'd always thought that what I did was something like DBT. But more importantly, there were a lot of differences, which I'll talk about in a minute, but it was good quality DBT. And the outcomes were essentially different, very similar. The therapists providing the good psychiatric management were not people off the street. They were people who were experienced for the most part and had something of a manual. It's basically the derivative of a book that Paul Links and I had finished in 2008, or published then. And they met as a group with him. And they were people who were self-selected and that they were clinicians from the community who liked or had experience working with borderline patients. So this trial was not meant to alienate Marcia. She actually was very complimentary about it, and that's good news. The structure of good psychiatric management is that it's once weekly individual therapy. It's case management oriented, focused on the patient's life outside of the treatment, not within the office. It's both psychodynamic and behavioral. And it starts with diagnosis and psychoeducation. That psychoeducation begins by talking with patients and their families in a very straightforward way about the diagnosis, about the hearability of it, about the course. That is, that most patients will get better with time, even in the absence of some kind of evidence-based treatment. And so there's a very optimistic tone that's set. There's also, by citing and discussing the heritability, it diffuses what has frequently been the case with borderline patients, that they actively blame their parents for all of the problem, and sometimes parents either defensively renounce that it's not our fault, or they absorb it and feel then that they're unable to set any limits on their kids. And is flexibly multimodal. It integrates and encourages involvement in groups, any group will do, and family interventions. It's got a theory behind it. This is a slide that I just made up this morning because the one I had didn't fit. Actually, I left my slides, and I'll get to that. The basic theory behind this is that the borderline's hypersensitivity to interpersonal interactions is what drives both the behavior and the emotions. So that contrasts with specifically the emotion dysregulation, which is seen as a sort of biological force in its own right in the DBT model. Here the person might get very wildly upset, but it's because of the meaning attached to what might be a minor event for somebody else, but is a major event in their psychology. The interpersonal features are the most discriminating aspects of borderline psychopathology from all other diagnostic groups. Adverse interpersonal events predict self-harm, suicidal acts, dissociation, and relapses, whereas positive interpersonal events predict remissions. And there's a strong developmental and neurobiological base which has been developed for this thesis. In practice, this is what it means, that when a borderline patient feels connected, they are idealizing, dependent, sensitive to rejections, but in the face of interpersonal stress, like perceived rejections, hostility, separations, or criticisms, they feel threatened. What in the mentalization world is called their attachment system is activated. And they become devaluative, self-injurious, angry, anxious, and help-seeking. If in response to being in that state of mind, their other, be it a therapist or other partner in their life, withdraws, which is easy to do by physically or emotionally, then they go into a state of aloneness where dissociation, brief paranoid experiences, desperate impulsive behaviors occur. If in response to that threatened state, there's a supportive response to it, rather than withdrawing, somebody leans forward, then they get connected again and they feel calmed by that and idealizing, dependent, rejection sensitive. The state of aloneness is one which often requires what is something more like being rescued and somebody actually taking hold of the person, whether it's giving them a sock or a physical contact or a hug or a hospitalization or something. Then there's a fourth state, which you don't see very often. Most borderline patients don't get into it, but at some point some of them give up on the idea that they can be or ever will be loved, and a state of despair where their suicidal acts then can be more final and irrevocable and less subject to good fortune or bad fortune. The 6 principles of good psychiatric management. First, be active, responsive, and curious, and not reactive. So you challenge the passivity, avoidance, silences, diversions, become a container for their anger and by being cautious and thoughtful, holding on to their accusations and criticisms of you without getting too reactive to it. I would say this is one of the major things that all the evidence-based treatments have in common, and that was such a departure, and in retrospect so straightforward, is that if you want to treat borderline patients, you have to be active. You cannot be impassive and oblique. You have to be very responsive. It's supportive. There's the non-specific ways via listening, interest, selective validation, but you show it too. There's a focus on life situations, the person's relationships outside of the treatment, and on vocation. There's an emphasis on getting a job. I wrote a case report, I think in about 15, 20 years ago, which Anthony Bateman and Otto Kernberg were discussing on. I noted that in sort of in passing, that there's an emphasis on work as opposed to love, because love relationships become so preoccupying and are so fraught with difficulty. Even the smallest little change in a love relationship can send somebody crazy. But if you get a job, it's inherently more structured, less conflictual, life and death is not connected with it, and it provides a source of self-esteem and structure, which is makes relationships as a buffer against the vicissitudes that go on in relationships. The relationship is real and professional, so you're permitted and even encouraged to make self-disclosures. There's a couple. Change is expected. So you start treatment with a statement like, I'd be glad to meet with you weekly, but I'd be reluctant to meet with you more often until we see whether I can be useful. We'll both know that by observing whether you feel better and whether these problems in your behavior and your relationships are getting better. And you monitor it. You talk with the patient, you keep that in the forefront of the treatment. That is the patient getting better? And if the patient isn't getting better, how come? It doesn't mean if the patient doesn't meet these sort of markers of change that it's a bad therapy. God knows there's a great deal of difference in the course of one borderline patient from another, but it is good to have some kind of markers, and above all, to have in mind and have in the patient's mind the expectation of change, and that you worry that there might be something wrong in the therapy if there isn't change, or if a patient's getting worse. That is definitely something to stop, get a consultation, and to be overtly concerned about with the patient. Because the course of this disorder is that the majority of people get well. Not everybody, but the majority of people get well. Slowly but surely they get well. So by 6 weeks, has the patient's acute distress diminished? Hopefully it might diminish before that, but if it hasn't, it's worrisome. Is the patient actively participating? Do they come in with things to talk about? Are they interested in what you have to say? Do you like the patient? That's a sorry statement, but it's a very important one. If you don't like a patient, you probably aren't going to be able to help them. By 3 months, as self-injurious, it's hard not to like a patient also if they're actively involved, so that some of this is a little circular. Has self-injurious behavior decreased? Self-injurious behavior has been a focus of DBT, and it's sort of fortunate in a way because it's so visible and measurable, but it is that criterion within the 9 that changes most rapidly. And it changes even in the absence of evidence-based treatment for the majority of borderline patients. It's just that evidence-based treatments expedite that, the speed with which that happens. But it should have happened by 3 months. The only reason DBT is a year, for example, is that they needed a year to get statistical power. It isn't as if after 9 months people started self-harming. The self-harm decrements start early and mount, and then they get large enough with the size sample that you have in any given study to reach statistical significance. Does the patient remember and apply lessons learned in sessions? Very important, and the clinicians are very important in expecting that. If the patient doesn't remember what went on in the last session, you say, whoa, how come I remember better than you? Has your understanding and empathy increased? It really should. 3 months, that's 12 sessions. I mean, really it should start almost within the first 10 minutes, but you really should get an understanding of your patient that grows by that. 6 months, has the patient assumed or resumed social roles or responsibilities? I think that's a fair time frame. We've actually changed it in our outpatient and even our residential setting, where we expect patients to get jobs or go back to school at least part-time by, 6 weeks or 3 months, or I guess it's more like 6 weeks. Even very disturbed people. Now, that's like, there was a time when you sort of threw up your hands, borderline patients don't participate in groups. they have to participate in groups, they participate in groups and they learn a lot from them. It's the same thing with work. They'll tell you they can't or they won't or da-da-da. If you make it a sort of an expectation requirement, the majority of them will and can, and it makes a huge difference in getting on with their lives. Does the patient relate behaviors or emotions to interpersonal events? Now, this is specifically something within the interpersonal hypersensitivity model that you expect patients, if they're having an emotional exchange, that it is something went wrong with Henry last night, and you don't wait. You ask in an open-ended way. If they don't volunteer it, they say, "So what went on with Henry?" Or if they cut themselves and they say, "I just feel awful," so what went on with Henry? You be proactive about it, and pretty soon the patients will make those connections for themselves without your needing to prompt it. And has the patient's trust in you improved? Sort of like the papers yesterday and the new emphasis that Peter is showing in epistemic trust as a central problem with borderline patients, that they're developing a trust in their clinician is a very important and oftentimes corrective experience. Accountability is another aspect of good psychiatric management, where we expect patients to take charge of their lives. We convey that they can and that they should, and that we hold them accountable within the therapy itself, that they should be remembering what has been talked about, and as well as in controlling their life. So here's where I failed you all this morning. I had a briefcase with all my slides and everything in it and a nice video, but I put it on the kitchen counter thinking I shouldn't weigh myself down with a heavy briefcase. So rather than this video, I'm going to have to try to recreate it. So the young woman comes in and she says, "Do you always mean what you say?" "Well, I try." "That's what I thought. I thought you were someone I could trust, who could understand me." "What?" She interrupts. "I don't think you're cut out for this work. BPD is a tricky condition, and I don't think you know what you're doing. I don't think you're up for it. You sit there with your self-satisfied grin, and you don't know what you're doing." "Well, please stop. I understand you're angry, but I don't know why." "I'm really interested." "Well, guess." "No, I've already put my foot in my mouth in some way I don't know. I'm reluctant to do it again." "Well, last week you said I was nothing if I didn't get a job." "Oh. And this week I say that I'll try to mean what I say." "Yes." "Oh, I'm sorry. I'm really sorry. I didn't mean that you'd be nothing if you didn't get a job. It was my awkward and unfortunate way of trying to make a point. And I shouldn't have said it that way. You're really a very special person." And the patient's relieved and says, "Well, I just thought that that you didn't want to work with me anymore and that you'd given up on me. No, I didn't mean that at all, and I'm sorry. But I did mean you really need to get a job. Oh, here we go again. So that's my recreation of the So what this video was meant to illustrate is being active and being very responsive to the patient, and being in response to the anger, sort of leaning forward rather than leaning back, getting interested, seeing where the patient was coming from. Oh yes, yeah, I see why you said that. Apologizing. The focus on getting a job is not incidental to this patient in this hour, but is something that is a very sort of recurrent theme within the good psychiatric management model. It, by the way, is related to the outcome studies where it showed that all the evidence-based treatments and the longitudinal course of borderline patients showed great reductions in the criteria and symptoms of the disorder, but were not particularly successful in helping people's social adaptation. So this is a very dedicated effort to bring that part of the patient's lives into the treatment and to reinforce the need for them to get a socially satisfactory life, as well as just reducing their symptoms. And mistakes are made, inevitable, and they're useful and they're reversible. It's often very good experience for borderline patients to have a clinician who acknowledges their mistakes, and they may feel, many of them, that they can't make mistakes, and this is a very good role model. In closing, borderline patients should be able to assume that the professionals who treat them have been trained to do so. Many psychiatric residency programs and psychology training programs and social work training programs do not dedicate their parts of their curriculum to helping students learn how to treat these patients. GPM's message in that respect is that there is an effective model for treating borderline patients which can and should be incorporated into training, and that will arm most clinicians, not all clinicians, are well suited for working with borderline patients, but most clinicians will be and can be well suited for treating borderline patients if they have basic training. And that's what the good psychiatric management model is meant to be. When we do workshops on good psychiatric management, usually those experienced clinicians in the audience, when you ask them whether they learn much, they say, no, but I feel more confident about what I'm doing. And what this is, and it's the sort of thing that you learn from experience. And it's good enough for the treatment of most borderline patients. At present, most clinicians actively avoid seeing borderline patients, and that's unfortunate. And those who fail to get improve with good psychiatric management, then that's when you refer them on to the specialists with DBT training or mentalization-based treatment training or TFP training. In the background of this is that there's a more general message that most everybody in this room will have already learned, is that it can be very satisfying to work with this group of patients And it's unfortunate to avoid them because of misinformation or a lack of training. You can take pride in we can take a great deal of pride in our skills now. If this message comes through to the next generation of treaters, we won't be able to say that we're better than our colleagues, because most people can learn these skills. Working with borderline patients involves personal growth. You don't do this without getting involved with your patients. It's a very interpersonally alive, meaningful relationship that is required. And it's, of course, finally then very rewarding to have a highly personal and usually much appreciated life-changing role. Thank you very much.